Good day, everybody. This is the lecture on dermatological pharmacology. So when we talk about dermatological pharmacology, we can approach it in two different ways. The first is, of course, talking about drugs that are used for the treatment of skin conditions. And in this context, we can talk about local application of drugs on the skin and, of course, systemic administration of drugs to treat generalized skin conditions. On the other hand, we can also talk about using the skin to administer drugs for the treatment of systemic conditions. So, yes, we apply drugs on the skin for treatment of skin pathology, but we also can apply them on the skin so that they can be absorbed into the circulation and used for treatment of systemic conditions. We will not be discussing this aspect of dermatological pharmacology in the present lecture. We have already covered this in the CMM course. We will mention just briefly some of the factors that are important in absorption of drugs. And this is the structure of the skin. No need to remind you of it. Remember that the blood vessels are in the dermis and the subcutaneous tissue, and that for drugs to be absorbed systemically, they have to traverse the epidermis, which is a multi-layered tissue, multi-cell layered tissue, and therefore the drugs can pass through this layer either intercellularly or transcellularly or through the appendages in the spaces within the hair follicle, for example, or the sebaceous glands. But predominantly it's transcellular and intercellular especially. And the stratum corneum, remember, is a barrier to drug absorption. It's a very tight structure. So the drug has to, in order to actually get absorbed, the first step is to get partitioned into the stratum corneum. And therefore drugs differ in their ability to partition from the surface of the skin into the stratum corneum. Those obviously which have a high partition coefficient are better absorbed, and this is basically the rate limiting step in the absorption of drugs. Now remember the factors that affect absorption through the skin. This is mainly a passive absorption, obviously. So the concentration gradient, the surface area, remember these, the lipid solubility, because it has to go through membranes, cell membranes. The smaller the molecule, the easier its transport and diffusion. In general, on the skin, hydration improves absorption of drugs. And that's why in many preparations you find that they tell you to place the drug on the skin and then cover it with a patch. Or they come already in impregnated, drug-impregnated patches, because when you close over the skin, you prevent evaporation, it becomes more hydrated, and therefore the penetration of the drug improves. And we'll talk about different preparations later on of skin preparations that differ in their ability to be occlusive versus non-occlusive. Sometimes the vehicle that is used in the preparation may help the partitioning of the drug. The thickness of the skin differs from one site to another, and you would expect that the thinner sites have better absorption, such as the eyelid, for example, is much thinner than the back, which is thinner than the soles of the feet. And remember that inflammation also can enhance absorption by increasing the vascularity to the site of application if you place it there. This is an example here at the top of a special preparation of a drug impregnated patch. The patch, it contains the drug on the inside of it, and you place it here. This occlusion is going to hydrate the skin or prevent its drying, and this will favor the absorption of the drug into the circulation. Creams versus ointments are two different preparations. They differ in the extent of water in the preparation. Ointments have predominantly very little water and predominantly are occlusive when you put them, whereas creams evaporate quickly. So ointments provide a better vehicle for or a preparation for absorption of drugs. And you have many formulations of drugs for local application. Uh, you have solutions, obviously, which is self-evident what a solution is. A lotion is usually thicker than a solution. It is not a solution, and you frequently you have to shake it so that you disperse the drug in the suspension. Creams, you know what creams are, thicker than a lotion, contain water, and some of them contain some oil and at low concentrations. Uh, Usually they require preservatives. Ointments, on the other hand, are semi-solid. They have much less water than creams, but usually they are greasy and sticky, and sometimes they leave stains on clothes if you put them. But in contrast to creams, they don't need as many preservatives or no preservatives, so allergy is rare relatively. Then you have the gels and the foams and other preparations. These can be aqueous or alcoholic, and usually when you place them on the skin, they become liquefied. Pastes like toothpaste is a concentrated suspension. Then you have the aerosols, which are solutions, but they have a pressurized container. Powders, solids such as your antiperspirants, etc. And then you have the transdermal patches that we mentioned earlier. It's a drug delivery system that contains the drug inside it at precise doses. And the adhesive is there so that you can cover the skin and enhance the absorption. Now, these different formulations have different applications, and depending on the condition that you're treating, you may want to choose one formulation over the other. For example, which choice of formulation? What is the nature of the lesion? If the lesion, for example, is wet and oozy, you want something that can dry it up. So you use creams and lotions, things that can evaporate, that have some alcohol in them perhaps, and can dry the lesion. On the other hand, if the lesion is dry and scaly, you want something that moisturizes it or keeps some fluid in it, like ointments and oils. When you have inflamed skin, you can use creams or ointments. Usually you use wet compresses and soaks followed by those. And if there are cracks in the skin, then be careful to avoid things that can irritate and cause pain, such as alcohol or acidic substances. Similarly, the site of the lesion can also affect the formulation. So on the skin, on the bare skin, palms and soles, you can use ointments or creams, but these are difficult to use on hairy areas. And here it's preferred to use things like lotions, solutions, and gels that can mix and reach the skin easily. In the skin folds, interdigitalis areas, these are already wet areas, and you don't want to use occlusive preparations here like ointments, but you use creams or lotions. And the same thing with mucosal surfaces that can be injured. You don't by irritating substances. You don't want to use irritating formulations or acids or alcohols. Transdermal delivery to have systemic effects. Remember that this bypasses the liver, so no first pass hepatic metabolism. However, it doesn't mean that everything you put on the skin gets absorbed. First of all, there are things that cannot be absorbed. Second, there are enzymes in the skin, the same enzymes in the liver, some of them, like cytochrome P450 enzymes, that can metabolize the drug as it's passing through the skin. There are also transporters that can pump the drug out of the cells, the multi-drug resistance genes, the P glycoproteins that you found in other cells in the body. And you have genetic polymorphisms in different individuals affecting both the enzymes and the transporters. And so, as a result, you get variability among people in terms of how much or the efficiency of the absorption through the skin. One very important point to remember is that children have a much higher surface area to body weight than adults. So when you administer drugs transdermally to children, you have to be very careful about dosing, and you have to use the surface area rather than the weight as the denominator, if you wish, in determining the dose that you need to administer. Otherwise, you'll be overdosing these children. So now that you have a skin disease which you want to treat by application of drugs, of course you have to have the correct diagnosis. You have to choose the right medication and the right dose. And as we said, the type of lesion being treated, we just mentioned these, the vehicle, which formulation to use on which kind of lesion, and finally the method that you use to apply the medication. In general, it is advised to apply these to moist skin, as we said, and after bathing, perhaps because there is some increased blood flow to the skin, or use occlusive dressings to maintain the hydration of the skin. So what are some of the drugs and what are some unique approaches relevant to treatment of skin conditions? Many of these drugs you will have studied already. Glucocorticoids, for example, you have already discussed them more than once before, so we're not going to dwell on them. But there are many types of steroids, some very potent like betamethasone, some less potent. So the concentration of the drug differs between one preparation and the other. Usually they are applied twice daily, no need to apply more than that. And you know their pharmacological effects. They are obviously the main reason you use them for the skin is as an anti-inflammatory agents. They can cause vasoconstriction. They are immunosuppressive also. That's another reason to use them in certain skin conditions. But they can be catabolic and they inhibit collagen formation. So they can have local effects on the skin that are adverse effects, if you wish. And when you use them systemically, you can also do that to treat systemic skin diseases, autoimmune skin diseases. So how does one determine how much ointment or cream one should put on an area? Say, for example, the face, or if you're treating one arm or one hand. So the unit that is used for this purpose is what is called a one fingertip unit, which extends, as the picture at the bottom shows you, from the tip of the finger to its first crease. And when you squeeze the contents of the tube and spread them along this will be one fingertip unit, and it's around 0.5 grams of ointment or cream. So here, as an example, if you want to treat a lesion on the face and neck and you want to cover this, you will need 2.5 fingertip units required. That's around 1.25 grams, right? So 2.5 times you have to do this. Whereas if you're covering the hand, one side of the hand, you will need only a half of the fingertip unit. That's corresponding to 0.25 grams of the ointment. Therapeutic uses, as we said, many localized inflammatory skin conditions can be treated with glucocorticoids in this manner. And you have the local and the systemic toxicity of steroids. So as we said, there could be degenerative changes because of the catabolic effects of steroids. Could cause atrophy and thinning of skin, perhaps by interfering with collagen synthesis, um, and especially apparent on the face. So it is advised not to administer too much steroids on the face or too frequently on the face, where the skin is already relatively thinner than other places. It can promote infection because of its immune effects. It can cause glaucoma. It's well known that steroids can enhance intraocular pressure and worsen glaucoma in patients. And of course, if it's absorbed, it can have potential systemic effects, and all the systemic effects that you have studied already, affecting metabolism, bone metabolism, etc. The systemic effects, of course, a lot of adverse effects that you can review from previous lectures. Now, another group of drugs that is important in the treatment of skin conditions are the retinoids. And these, again, can be used systemically or topically. The retinoids are basically natural or synthetic derivatives of vitamin A, which is known as all-trans retinol. And these substances have a role in embryogenesis, in reproduction, cell growth and differentiation, and also in regulation of the inflammatory response. And in the skin in particular, they also regulate keratinization and cell proliferation. Now, there are a lot of retinoids in the market. They are divided into first generation, second generation, and third generation. Third generation and second tend to have less adverse effects than the first generation. So vitamin A is all-trans retinol. Tretinoin and L-tretinoin, etc., are first generation. And as you can see, you don't have to memorize all of these names, but they are here just so that you'll be familiar with them if you encounter them later. How do they act? They have their own receptors called the retinoic acid receptor, AAR, RAR, or the retinoid X receptor. And these are a steroid family of receptors. In other words, they are intracellular, intranuclear receptors. And each of these two receptors has subreceptors, alpha, beta, and gamma, which are differentially distributed in various cells. What happens when a drug binds to RAR or RXR? What happens is that there is dimerization of RAR and RXR. So they form a dimer, and this dimer, or heterodimer, there's an O missing here, it binds to the DNA and activates transcription. And these transcription products are the ones which mediate the effects and also the adverse effects of the retinoids. So here is a more detailed view of what is happening. So this is the RAR ligand, the circle, and the receptors RXR, RAR are a dimer which can bind to retinoid response elements on the DNA. In the presence of the RAR ligand, this binding happens here on the RAR, let us say, receptor. And what happens is a conformational change in the receptor that gets rid of a repressor of transcription that is bound to RAR under normal circumstances. In the absence of the RAR ligand, there is an inhibitor of transcription bound to RAR. When the agonist binds to the RAR receptor, this repressor is kicked off, and in fact, what happens is an activator binds to RAR receptor, and this triggers activation of transcription. Now, in general, if the target of the retinoid is the RAR, such as tretinoin, the effect is on cell differentiation and proliferation. And these kinds of drugs are usually effective in acne, in psoriasis, where they correct hyperkeratinization and excessive sebum production, and also they limit hyperproliferation of cells. And they restore normal epithelial differentiation in psoriasis. They also can help in photoaging by decreasing wrinkles and dyspigmentation. If the target is RXR, as for example in alloretinoin, it seems that these drugs tend to induce apoptosis, and therefore they are used in certain conditions such as cancers of the skin, Kaposi's sarcoma, and cutaneous T-cell lymphomas. Now there are some drugs that resemble the retinoids. They are not retinoids, but retinoid-like. Actually, this calciprotein is an analog of vitamin D that, however, also complexes with the RXR receptor to form a dimer, and again acts in the same manner to affect differentiation and proliferation. So the adverse effects of retinoids are many. Topically, they can cause redness, desquamation, burning sensations, and photosensitivity. In other words, when exposed to light, these sites which have retinoids can have reactions and severe sunburns. So when used, the patient is advised not to get exposed too much to the sun. But they also have a lot of systemic effects, as you can see here. Hair loss, CNS effects, metabolic effects, muscle aches, photophobia, photosensitivity, and so on. And finally, because of their involvement in embryogenesis and development and reproduction, they can be teratogenic. So it's absolutely contraindicated to take them during pregnancy. Another approach in skin pharmacology is what is called photochemotherapy. Now, this is a broad term that simply means that we use radiation, light, ultraviolet radiation in this case, to induce a therapeutic response. And this is in the presence of a photosensitizing drug. In other words, you give the drug first, either topically or systemically, and then you expose the patient to ultraviolet radiation. And this interacts with the drug and causes an effect. So before we go into the drugs that are used, just a reminder that ultraviolet light itself has effects on the skin. Ultraviolet light of a certain frequency between 200 and 320, which is also called UVB light. This is the one that usually causes the most burns, tanning, and also has a risk of causing skin cancer and photoaging. Ultraviolet light of a bigger wavelength, UVA, which can be UVA2 or 1, is less erythematogenic than ultraviolet light B, but penetrates deeper. It does contribute to photoaging as well, but it's not the one that's mainly responsible for the burns and the tanning that you see. Now, photochemotherapy consists of giving a drug, and usually these are psoralens, together with UVA light. So the psoralens are the drugs that are activated by the ultraviolet light, and they can be given systemically or locally depending on what you want to treat. What do these psoralens do? Well, normally if you give them, they go to the DNA and intercalate between the strands and the bases. However, if you expose them to ultraviolet light, what happens is that they then form covalent bonds with the base pairs, pyrimidine bases, in the DNA, and end up having cross links and between the different strands of between different strands of the DNA, such that you basically inhibit the replication of the DNA and mitosis, and therefore, as a result, they have an anti-proliferative, immunosuppressive, and anti-inflammatory effect. And this is represents what happens. This is the sorrelin with, and under normal circumstances, when there's no light, you simply intercalate. The sorrelin intercalates within the DNA. It's a complex, but it's not irreversible and not covalent. However, when you when you expose them to ultraviolet light, you form adducts between the sorrelin and thymine in this manner here, and you can have different kinds of adducts at different sites in the molecule, and eventually you can cross-link them, the various bases, thymine here versus thymine here, and you can cross-link them with the sorrelins. And this is what inhibits replication and mitosis. And conceivably can cause breaks in the DNA as well. So the therapeutic use of photochemotherapy in psoriasis, very beneficial. Hyperpigmentation, loss of pigmentation in vitiligo, and in other conditions such as atopic dermatitis, alopecia, which we'll show some examples. Toxicity consists of skin burns, a risk of cancer, as well as degenerative changes. The ultraviolet light can cause ocular toxicity, but you can prevent that by covering the eyes. But there are many, many other which we don't have to go into. These are examples of the success in psoriasis. This is the seborrheic form, this is the plaque form of psoriasis, and this is the response to therapy, photochemotherapy. Another form of phototherapy is photodynamic therapy. It's basically similar to photochemotherapy, except that here you're not using ultraviolet light, you're using visible light. And the drugs that are commonly used here, the agents, are porphyrins, particularly aminolevulinic acid, ALA. And again, the mechanism here is that when you expose ALA to light, they are activated and result in formation of reactive oxygen species. These reactive oxygen species will oxidize cell membranes and cause damage leading to apoptosis. And particularly the ALA is concentrated, or especially concentrated in the epidermis, sebaceous glands, as well as neoplastic cells. They take them up more avidly. And so when these are the sites that are more targeted or more exposed to injury when the person is exposed to light. And therefore skin cancers, neoplastic cancers, acne having to do with the sebaceous glands, and also photodamaged skin can be benefited by this type of therapy. We're not sure how photodamaged skin is benefited. Possibly there is a question that they might induce collagen synthesis. So remember that ALA is what? Is the precursor of heme. And it's produced through ALA synthase. Under normal circumstances, this cycle produces heme, and then heme in turn inhibits ALA synthase. And so you regulate the availability of these substances in the body, in the cells. However, what you're doing here is that you're administering ALA exogenously. So you are bypassing this rate-limiting step in the synthesis of heme and porphyrins. And so you have higher concentrations of ALA and other porphyrins in the system, or wherever you are administering the ALA, the area you're administering it. So remember that when we talked about heme metabolism, we said there are defects in enzymes in the heme synthetic pathway that can lead to accumulation of porphyrins. And we mentioned that this results in various manifestations in the patients, some of them having skin conditions, photosensitivity. In other words, when they get exposed to light, they can get skin injury. And that's basically similar to what you're doing here, except that now you're applying the drug on the skin and you're exposing it to light to have a local or a localized toxic effect. There is low potential for DNA damage here, uh, but you can get burning sensations and erythema, edema. It could be quite severe sometimes. Pain can happen, and desquamation and peeling and erosions can happen to the skin. So we go on to other groups of drugs that are used on the skin, and one that is commonly used in the summer are sunscreens, and basically these are there to provide protection from the effects of sun exposure, from burns, sunburns, and potential for cancer development. What happens is that these compounds found in sunscreens absorb ultraviolet radiation and transform it to heat energy, and also to inorganic agents that act as blockers or as substances that reflect ultraviolet light and scatter it and prevent it from being transmitted to the skin. So it's been shown that regular use of sunscreens protects against carcinogenesis and against aging of the skin. So we classify them according to a parameter called the SPF. The SPF is the sun protection factor, and basically it is calculating it is calculated in the following manner. You find the dose of ultraviolet light that induces a certain degree of reaction, erythema, sunburn, or whatever on the skin. And you find this dose in the presence and in the absence of a sunscreen. So how much higher should the dose be to induce the same degree of sunburn in the presence of the sunscreen is an indicator of how effective this sunscreen is. So the higher the ratio of the dose plus the sunscreen over the dose minus the sunscreen, the more protecting the sunscreen is, and the higher the SPF value. So this is a general guideline on how protective it is. And remember that these compounds can be organic and inorganic substances. Both of them can work as sunscreens. And these are some of the agents that are used. Of course, you don't have to memorize them. Another class of pharmacological agents are those used to treat androgenic alopecia. Remember, this is loss of hair that causes the normal male pattern baldness, and it is usually due to the binding of the male sex hormone, dihydrotestosterone, to its receptor, activating genes that lead to hair loss. So you will see that the drugs that are effective here are drugs that can inhibit, for example, here, the synthesis of DHT, and as a result decrease the effect of DHT. Finasteride is such a compound. Its adverse effects have to do with a decrease in male sex hormones and include erectile dysfunction and decreased libido. But another compound that is commonly used also for stimulating the growth of hair here is minoxidil, which was originally developed as an antihypertensive agent. It's a vasodilator that acts by opening potassium channels. The exact mechanism by which it induces hair growth is not known, but it's something that was discovered, I think, serendipitously. When you apply it to the hair areas, you have to be very careful how you apply it and where you apply it, because if you apply it by mistake somewhere where you don't want hair to develop, actually hair will grow, will develop there. So enhances the follicular size of the hair follicle. You get thicker hair shafts, and you can see what happens here. The problem is that you have to continue administering this for ever if you want the hair to continue growing and being present. If you stop treatment, you lose whatever hair you have gained. So it's a reversible process. The same applies to finasteride. So there is no magic formula to allow hair to grow and you go back to normal. You have to continue giving these drugs or taking these drugs. Conditions where you have hyperpigmentation are treated with a drug called hydroxyquinone. This is a drug that decreases the production of melanin by inhibiting its synthesis through the enzyme, inhibiting the enzyme tyrosinase. We'll depict the figure in just a second. So it is used for treatment of light-induced pigmentation or hormone-induced pigmentation within the dermis. Limited efficacy, although it might be effective in some cases of post-inflammatory pigmentation, but it is limited. Here you have an example of melasma, a patient with hyperpigmentation on the cheek here, treated with hydroxyquinone, and you can see the relative reduction, although it's not completely gone, as you can see, but it's significantly reduced. Remember that melanin is synthesized from tyrosine through a series of enzymes that can lead to production of different kinds of pigments, brown or black melanin pigments called eumelanins, and yellow or red pigments called pheomelanins. And remember that tyrosine also, just to remind you, is the precursor of the catecholamines, as well as important the synthesis of thyroid hormone. But what you're doing here is you're inhibiting basically this pathway, the tyrosinase mediated pathway, which leads to melanin production. And you have many other classes of drugs that exist as dermatological preparations. Antihistamines for allergic reactions, antimicrobials, all sorts of antimicrobials, immunosuppressive agents, chemotherapeutic agents, immunomodulators, keratolytics for hyperkeratinization, and a drug called capsaicin, which is can be used for pain, reduction of pain. It's a substance that depletes substance P, which is a peptide that is involved in pain sensations. So it can also be applied locally. Now, moving on to a whole different group of agents that are not that do not have really active agents in them, but they have some effects on the skin resulting from their physical properties. For example, demulcents are substances which protect and soothe the parts to which they are applied. So, particularly useful for irritated skin. Things like glycerine, acacia, and agar have that property. Emollients are moisturizers. They are used basically to hydrate and soothe the skin. And they do this by forming an oily layer, as we said earlier. So they're good for dry, itchy, or scaly conditions. Astringents are substances which specifically effective in areas where there are ulcers or wounds, because they reduce exudation and secretion from tissues. And finally, caustics are, on the other hand, agents that actually destroy certain outgrowths on the surface of the skin. For example, warts, polyps, etc. And these are substances such as acetic acid, podophyllum, other forms, trichloroacetic acid, and silver nitrate. So you can apply them directly to the lesion and they sort of burn it and destroy it. And finally, we have antiseptics and disinfectants. Disinfectants doesn't really apply to skin conditions, but we are putting it here just to distinguish and to distinguish between them so that you will not use them interchangeably. Antiseptics are agents that are applied to the skin to sterilize it. So if you want to inject something into the skin or withdraw blood, you usually apply either alcohol or some other substance to the skin to sterilize it, and then you penetrate the skin. Otherwise, you might introduce infection. Similarly, when you want to do surgery, etc. So the antiseptics are usually broad spectrum, germicidal agents, and with minimal, of course, local effects. Disinfectants, on the other hand, are substances that are used to sterilize equipment, such as surgical equipment. But they may be harmful if applied to the skin. So we don't use them as antiseptics. And this is important, just a note here. Sometimes the efficacy of the agents depends on a proper exposure. In other words, you do not sterilize the skin if you simply place alcohol for 2 seconds on it. You actually have to place the alcohol for 36 seconds as a minimal contact time to really sterilize the skin. And if you actually observe the practice of most people who use alcohol to sterilize the skin, nobody usually waits 30 seconds before doing the procedure. So alcohol 70% is the ideal solution or concentration to be used as an antiseptic. Lower concentrations and higher concentrations are both less effective. So apparently there is a balance between alcohol and water that is ideal for disrupting the cell membranes of the microorganisms that are being affected, such that even if you have a higher concentration of alcohol, it will not work as well. It's not optimal. Benzalkonium chloride, another antiseptic, minimal contact time is 7 minutes. So it's not a good thing for rapid procedures, for when you're in a hurry. Other antiseptics, as we said, alcohol 70% or isopropanol 70% or higher. This is bactericidal and virucidal. It precipitates proteins and lyses their membranes. However, it's not active against spores and fungi. Of course, we don't apply them directly to wounds. They could coagulate proteins and that could be very painful. Iodine, on the other hand, kills everything. 2% iodine is one that is used. It could be a solution and it could be dissolved in alcohol, a tincture. So it kills bacteria, fungi, or microorganisms. And the solution, not the one that contains alcohol, the solution can be applied to wounds directly, in contrast to alcohol. Chlorhexidine is probably the most commonly used antiseptic in operating rooms, and it's used to scrub before operating. It is bactericidal, but again not effective on spores. Some drugs can be both antiseptic and disinfectant. Sodium hypochlorite, which is the common bleach that you find in kitchen appliances, kitchen preparations, can be used at certain concentrations, very low concentrations, to be applied to the skin. Again, it kills all microorganisms. Hydrogen peroxide, no, the hydrogen peroxide can produce, as you know, free radicals, oxygen-free radicals, can cause damage to living tissue. And benzalkonium chloride, the one we mentioned earlier, also a broad antimicrobial agents. Finally, some drugs are only used for sterilization of instrument, because if you put them on the skin, they can be quite toxic, so you don't they're not tolerated. Glutaraldehyde and formaldehyde are examples, and they are broad spectrum, again, drugs. So this ends the section on uh, dermatological pharmacology. If you have any questions, please email me anytime. Thank you.